myositis. There is another case of myositis, inflammation of the muscle, and variation of an hamstring lesion. There is the lesion in March, in April, and in May, the follow-ups. You can see the myositis ossificans. Muscle atrophy is another thing. In muscle atrophy, the hyperechoic muscle is having more muscular bundles, fatty infiltration, and this atrophy is caused by a denervation of the tendon rupture. Muscle avulsions, very common in calf. There is muscle avulsion, and medial gastrocnemius, subaponeurotic avulsions may be seen. Then is muscle herniation. Avoid the compression of the probe. If there is suspicion that the muscle is herniating, it will be herniating towards the skin, towards your probe. Delayed onset of muscular soreness is another important thing. Delayed pain, muscle hypertrophy and soreness, quick resumption of activity, and diffuse hypertrophy, hypoechogenicity of the muscle bundles is seen in soreness. There is soreness in the muscle. Then comes muscle tumors. Tumors can be malignant or benign. Here we have malignant fibrohistiocytoma, which was confirmed on biopsy, and there is a vein, and you can see a mass-like appearance of hemangioma. A desmoid tumor, myxoma and schwannoma. In conclusion, we can say muscle ultrasound is very efficient in the diagnosis of muscle pathology. The examination must be performed as soon as possible, but not within the first 2 hours. Follow-up is mostly indicated in dubious lesions, difficult patients, or lack of a correct treatment. Clinical examination is still mandatory. Thank you very much. Bismillahirrahmanirrahim. The topic is tendon ultrasound. There are different tendons in the body, and we can scan all of them, including all limbs, and we use a linear probe, and for small tendons at the extremities, at hand, at foot, we need a hockey probe, which is also called pencil probe. Major tendons with no tendon sheaths include Achilles tendon, patellar tendon, and quadriceps tendon. These are the main tendons, like Achilles tendon, which is without sheath. There are few tendons with sheath. The normal ultrasound appearance of tendons is hyperechoic compared with muscles, composed of multiple longitudinal echogenic bands, and echogenic margin corresponds to the epitendinium. Tendons without a sheath are surrounded by a loose fatty connective tissue called the paratendon. The tendon sheath is seen as a thin hypoechoic line on the margin of the tendon. A small amount of fluid in the tendon sheath may be normal. Here we have a tendon. It is Achilles tendon. In longitudinal direction we can see the bundles, and there is no tendon sheath. Extensor pollicis longus, the tendon, and then there is tendon sheath. There is peritendinosis. Again tendons with anisotropy. This is anisotropy. It is an artifact. When we change the angle, we will get that it is normal. Other tendons in the shoulder joint. The tendon pathologies include tendinopathy, which can be acute, subacute, chronic, or calcific. We can have tenosynovitis, enthesopathy, rupture, and bursitis. The sonographic signs of acute tendinopathy include swelling, decrease or inhomogeneous echo texture, fluid in the tendon sheath, and calcification. Here we have a tendon which is normal. When we compared with the other side, this tendon had more area. It was more hypoaquic. There was some fluid around it, and it was acute tendinitis. In chronic tendonitis, we can get calcifications, but in shoulder, as here we can see in bicipital groove, this is bicipital groove, and here is the transverse ligament at bicipital groove. This is biceps tendon, and here is some fluid. Achilles tendon, here is the normal appearance of Achilles tendon, longitudinal direction, and on transverse section it appears like this. This is the proximal to distal, and we can have some calcified areas. In the previous slide we had some areas. These indicate there is intrasubstance tears. Here is calcification, chronic tendinitis. And then we come to patellar tendon. This is a longitudinal view and transverse view, and the patellar tendon is showing multiple areas which are hypoaquic, indicative of tendinitis. This is longitudinal and transverse view showing chronic tendinitis. Small calcifications are there. Another tendon with inflammation, hypoaquic and hyperaquic area, indicating calcification, which is a sign of chronic tendinitis in the left knee. Here is a case in which there was foreign body which caused rupture to the tendon, resulting in tendinitis, which changed into chronic tendinitis, and this was the entry of foreign body. Coming to tenosynovitis. Tenosynovitis is the involvement of the muscle in the tendon sheath with fluid. Here you can see the malleolus and tendons, which are the peroneal tendons within the sheath, showing tenosynovitis. Tenosynovitis can be confirmed by changing the angle of the probe. Here is some fluid. This is tenosynovitis. Cross section, you can see the inflamed tendon along with fluid in the sheath. This is again thickening of the tendon, which is tendinitis, along with fluid. It is tenosynovitis. Then coming to tendon tear. A tendon tear will have discontinuity. It can be confirmed with, we can have correlation on surgery. This is the defect at tendoachilles. This is transverse and longitudinal. Here is biceps femoris showing the tear. Here is again biceps tear. Then tendon avulsions occur in immature skeleton. Here is tendon avulsion. Will have changes in the bones. Here are the changes in the bones and the tendons. Then we can assess tendon tear. We can have follow-up scans, and we can see that at follow-up the acute changed into chronic. This is longitudinal and transverse view, and we can find the tears there. Here is again a scar and a tear in the tendon. This is that scar. Here is the middle part of the patellar tendon, and this is prepatellar tendinitis along with deep infrapatellar tendinitis. Here we have flexor digitorum profundus, and we can see there is inflammation of the tendon. The muscle injuries are delayed onset muscle soreness can be diagnosed. Distraction injuries include muscle strain, partial tear, complete tear, and compression injuries cog thigh. Here we have intrasubstance. This is called sprain. or minimal partial tear or grade 1 tear. Here is biceps superior to the inferior side, superior from the inferior side, and here we have partial or minimal partial tear, which is grade 1. Another left biceps humerus, here we can see a tear, intrasubstance tear, which is of grade 1. Then we have grade 2 in calf. You can see a lot of area is involved, but whole of the tendon is not torn. Then comes complete tear, whole of the tendon is torn, it is going to one side, it is called bell clapper sign. Then coming to facial tears, the fascia can be torn. This is the fascia, we have fascia, this is fascia between the muscles. And transverse view of the vastus intermedius showing tear. Miscellaneous soft tissue pathologies include plantar fasciitis, hematoma, ganglion cyst, DVD, tumors, joint effusion and pathology. Always look where the patient thinks the problem is. This is very important. Then comes plantar fasciitis. We have discussed this thing in our lecture on ankle and foot. We will scan the fascia and there is thickened fascia. Here you can see thickened fascia with some fluid. And a cyst between tibia and talus, it is a ganglionic cyst in the foot near calcaneus. And here is vein with thrombus, DVT, a patient with diabetes. And near to the knee on the popliteal fossa we can find Baker cyst having continuity with the knee. Here is again in the hip, there is bursitis in the hip, and angiofibroma, it can be confirmed on Doppler. Pigmented villonodular synovitis is another finding, we can have that. And here is left foot, and you can see a lesion there, soft tissue tumor.